Next we have with us Dr. Subbiah sir, one of the most distinguished speaker. He is the professor and head of Sri Balaji Dental College and Hospital, Chennai since July 2015 and professor at Sri Balaji Dental College Hospital since May 2005. He became the postgraduate teacher since March 1998. Sir had done his undergraduations in Annamalai University in 1992 and post-graduation in Tamil Nadu Government Dental College. He has been the examiner at various universities in Tamil Nadu, Karnataka and Kerala. Sir has a huge number of publications to his credit. He is also the journal reviewer for the Journal of Conservative Dentistry, Indian Journal of Dental Research and Journal of Multidisciplinary Dentistry. He is also a member of IACD, AAE, IDA and ISDR. I take this privilege to call upon Dr. Subbiah sir to share his knowledge on clinical challenges in non-surgical retreatment. I request Dr. Pradeep sir to please chair the session, sir.
So how are you all feeling? After the lunch, one session is over. I think thanks to Tilnagam sir for putting me to the second session after lunch. The blood supply is back to the brain, I suppose. The first session was always difficult. Good. So this lecture is basically I wanted to make it more clinically oriented. Because when Srinivasan talked to me, he was saying that it's mostly we are choosing clinical topics. So I thought I'll bring in a lot of my clinical experience with about 22, 23 years of experience here and in retreatment. So to start with, you'll see a slide talking about pessimism and optimism. 23 years back when I started my practice, doing a root canal treatment was itself a practice builder. Because not many clinics, not every clinic was doing root canal, and it was easy to build up the practice with root canal. Today, you know, every clinic does root canal. Either they're endodontist, or they call a visiting endodontist, or they themselves do it. But there is not even one clinic who say that I don't do endodontics. It was not there 25 years ago. So, what is the practice builder for you? I feel at the time as an endodontist, we should be doing what the others are not doing. What others see it as a problem as a pessimist. When they see a failed endo, a non-endodontist will see it as a problem and advise an extraction and going for an FPD or an implant. But as an optimist, I think it's time when we realize this is an opportunity for the endodontist to start doing retreat odontics, what we used to call it a long time ago. So we retreat the tooth and save the tooth. And that is something probably one of the practice builders you will have. So this is, with that, Winston Churchill's quote of how optimistic we should be to use the opportunity and grow is what I'm starting with. I am Dr. A. Subbiah from Balaji Dental College. So we're going to talk on the challenges in root canal retreatment. And at the outset, I thank Dr. Tilnagam sir and Srinivasan and his team for inviting me and giving me this opportunity. Before we start about the failure, let us talk about what is success. There are various authors who have given what success means. Of all, the most simple and most practical is what I see from Shimon Friedman. Of course, the clinical normalcy is always there, because without that, there is no success. And the best form of success is clinical and radiographic normalcy. The next form of success is clinical normalcy with a radiolucence which is coming down. Initially, if it was there and it is coming down, it is again successful. And at least it should be remaining stable. It should not increase. So, least possible outcome we can expect as a success. That's what Friedman says. But if that is so, why does a treatment fail? Of course, Grossman gives it in a very simple way. Poor prognosis, you have chosen a tooth with poor diagnosis, poor prognosis, technical difficulties, and careless treatment. Of course, careless treatment, Jagran probably puts it in a different way. Inadequate cleaning and shaping, inadequate obturation, and coronal leakage. Coronal leakage being one of the most important causes for root canal failure. And almost all, I wouldn't say, with Pradeep here, I know one of the reasons for root canal failure is VRF, and almost all cases of root canal failure is from microorganisms. And the success rate is 85%. From various studies, including systematic review by Torabinijad, success rate is about 85%. And microbes is the cause, even in cases where the instrument breaks inside the root canal. It's not the instrument which is the reason for failure. It's not a ledge which is the reason for failure. It is not a perforation which is the reason for failure. They result in microbial presence there. That is the reason for failure. So ultimately, most of the cases fail only because of microbes. And this is a case, which is an interesting case, which I've been, not very interesting for me, it is very interesting because this is my first case of separation of instrument, my case of separation of instrument. Of course, this is nearly 17, 18 years ago when I started using profiles, which was the first introduced to us in India as a rotary instrument, commonly available. Because other generations were available. Most popular to be first is profiles. So this was the one which I broke. And that girl, I remember, she's still coming. Now that particular tooth gave me sleepless nights because that was the first breakage. Gave me sleepless nights, and I've been following it every time when she or their parents come for treatment. I ask, how does it feel? How's the tooth? The 1/6, whatever. I mean, her in case, she says, I'm all right. I'm all right. I mean, that gives me comfort. I never told her. For a lot of people have a different opinion about whether you should tell them or not that there's a fracture instrument. And this was a very recent, not even a year, when she came to me. And still going fine. Look at that palatal. I'm sure all of you recognize this, isn't it? Look at the palatal, it's got a nice lamina dura. PDL space is very fine. Everything is fine. So ultimately, it proves that this is not the broken instrument, but the microbes. Other causes, as I told you, vertical root fractures, and how Payner Nair puts it, cholesterol crystals, talc, and cellulose are all various reasons for failure. If microbes are the reasons for failure, how do we prevent it? What is the reason by which microbes are still there to cause a failure? First of all, of course, very good isolation. If it is not done, then the failure is very, very imminent. So long-term failure is imminent. Isolation, of course, damn it, that's the best form of isolation. And the other things are all, again, you can see, incorrect irrigants will retain some bacteria, and these other also retain the bacteria inside the root canal, resulting in a failure. So Pitford puts it in a slightly different way: poor cleaning and shaping, poor obturation, and resistant bacteria and crown root fracture. This case, you see this is one of my cases where I did the retreatment. I'm not very happy with the obturation, and given the cleaning and shaping, I thought it's a two different canal, but it was a single broad canal. So that means cleaning and shaping was not good. Then this is a coronal leakage again, and this is again poor restoration, because the coronal leakage, the restoration not only results in coronal leakage, but look at the crown ferrule is not there at all. Absolutely. So this resulted in coronal leakage, but this case, I don't know whether you can appreciate that it failed because of fracture of root rather. So this one is again a poor coronal restoration. And this is a vertical root fracture, typical picture of vertical root fracture, radiolucent line alongside the gutta percha. So these are various non-microbial causes. There's these two non-microbial causes of failures. And this is again an interesting case. This is done by me about 15 years ago. There was the first cracked tooth I had treated. So because when we were postgraduate students, generally we were told if it is a cracked tooth, if it is gone for pulpitis, it is indicated for an extraction. So, I thought, okay, let me try treating, because patient was very adamant not getting the tooth extracted. I told him about the prognosis and did the root canal. And after about 6-7 years, he came back with a small palatal swelling. Of course, the crack was not in the palatal area. It was actually in the mesial marginal ridge. So I removed the crown, and you can see that is the crack which was there originally. But that probably was not decent failure. Probably I thought that being a first molar, I missed a mesiobuccal canal. So, but the X-ray did not show any. Then I removed the, under magnification, I found there's probably a sign of MB2 or MB3 there. But the first thing which I wanted to do was the palatal, because see, look at that palatal, you are able to see that fracture line. So probably apart from this crack, there was also a crack there. So first I started off removing the GP from the palatal portion, and I found there was a cracking sound. So I had to remove the rubber dam and see what it is. And this palatal crack was this. So this is one of the cases for crown root fracture. Mind it, though this is my first crack tooth treatment and failed after 5, 6, 7 years, all the other crack tooth are still surviving as far as I follow. So crack tooth are good to treat, no need to extract. That's what my experience says. So coming to the diagnosis of failure, as I told you, I'm not going to, because retreatment as such can be a symposium, because it's a very large topic. So I'm trying to be a little bit theory and a little bit my experience, I'm mixing it up. So I'm not going too much into diagnosis, too much into anything, just superficial here and there. And, but this is something which you cannot miss. When you say diagnosis, differential diagnosis, this Crump et al. Poor past should be there. So this is the explanation: perforation, obturation, overfill, missed root canals, periodontal disease, another tooth, split tooth, and trauma. This could be the various differential diagnosis if the patient comes with a root canal failure. So this is again poor obturation. This is the various teeth I've treated. Poor obturation, very, very common in wide open apex. I was a victim of root canal failure for a wide open apex. I was treated by a non-endodontist. It failed after some years when I was doing my BDS, and it had to be retreated when I was doing my MDS. So this is very common picture. Very often non-endodontists do an obturation like this, and it's a failure. And of course, missed canal. This is again a C-shaped canal is not easy by a non-endodontist. Even for an endodontist, we take a lot of time. So C-shaped canal. This looked apparently all right, but I will come to this tooth in this case a little later. And this case was done by me, and after about few years, he came with a draining sinus. So I checked the adjacent tooth is fine. There is not draining from here because it's in between. So I guessed probably for here or here. So it's not this caries free. I took a radiograph, caries free, but apparently a large radiolucent lesion in the mesial root. So is it a root canal retreatment case? Should I start with the root canal retreatment? This is something which I want to tell you. When you get a case, you've been always taught to take multiple angle radiographs, be it primary treatment or even retreatment. So when I went for a multiple angle radiograph, so that's the mesial angle. So, and that's a distal angle. You see that? That large radiolucent line alongside the gutta percha is a classic sign of a vertical root fracture. A J-shaped radiolucency with a radiolucent line alongside the gutta percha is a classic sign. So VRF, it goes for extraction. So now coming to the retreatment as such. In simple words, Ruddle says, remove the restorations like crown, remove the root filling, and address the deficiencies for what the root canal failure occurred. Missed canal, ledges, perforations, whatever. Address the deficiencies and three-dimensionally clean and pack the root canal system. So success of surgical endo. The other alternative is surgical endo. So what is the success of surgical endo? Some authors say it is equal success rate, but the recent, or rather one of the in terms of systematic review, 2009 was one of the latest systematic review on retreatment by Turabinijad. He says long-term success is better in terms of for a root canal retreatment than a surgical endo. So look at that, his conclusion. So long-term success for a non-surgical endo is 83% versus 72% for a surgical endo. So not only that, its success rate is high, it is also cost effective. If surgical endo may be a little cheaper, but if it is extraction followed by a bridge, or if it is extraction followed by an implant, is certainly more expensive. So again, the option is for us to do a non-surgical retreatment and not extract or FPD. So coming to the indication for surgical endo, or in other words, a contraindication for non-surgical endo is, of course, presence of periapical lesion. Indication of orthograde retreatment. Of course, Gutman's indication for retreatment, periapical lesion and failed primary, and post-endo restoration in which there is no pain or anything, but post-endo restoration where it is poorly treated. And I don't know whether you see the bottom one, exposure of the root filling, for, the obturation in the oral cavity is again, you cannot just go ahead and do the crown. You will have to retreat it. And this is these are the various indications. Look at that. That's the typical cases. And this patient came to me asking for a crown. I said I wouldn't do it because after doing the crown, after a few years, if it fails, the blame comes to me. So I told the patient, no, I cannot do this. I have to retreat it and then do it. So also this patient, you have a cell point filling, poor axis filling. Again, you will have to retreat it. You cannot, even if it is asymptomatic, I feel these are all indications for retreatment. And pain or swelling where there is no apparent periapical lesion. Yes, patient has got symptoms, clinical normalcy is not there, so you have to do a retreatment. Sometimes you don't see a periapical lesion at all. So, but still the patient is not happy, not comfortable, you have to probably think of a retreatment. I'll discuss about a case, and where there's a lesion is increasing in size, but still the patient is asymptomatic, you will have to advise a retreatment. This is an interesting case which an orthopedic surgeon came to me that he said he did this root canal some years ago and he's got pain. I took a radiograph. Okay, I mean, probably you can find some problems here. You can say one of the root canal is not filled in the apical third, probably that's the reason. But I did not see the typical apical lesion here. I mean, I said it's probably some periodontitis. I did some deep scaling, this, that, I asked him to do flossing. But there's a good contact. The contact was good. But I was wondering what's the reason. Again, he came back to me after a month or two and said, no, doctor, this is still paining. I want to do something about it. And then I sent him for a CBCT. This was the CBCT finding. Look at the radiograph, no lesion. Look at the CBCT finding. Look at the apical lesion. And I started with the root canal retreatment. And then I placed calcium hydroxide. And he disappeared. As long as the pain is there, he was coming to me over and over again. 3 months of calcium hydroxide, he came back. I told him, okay, let me take one more. He said, I'm absolutely fine, doctor. It's a miracle. He said, it's not a miracle. It's a simple retreatment. Get another CBCT. So I got another CBCT to find it because there's no radiographic evidence of healing. So I took another CBCT. Good. So look at that. 3 months of calcium hydroxide, which was not changed at all. Look at the bone formation here. Look at the apical lesion. I don't know, in order to see that in the bottom. This will be able to see. That's the healing, and that's the post-operative. I mean, the radiographically it doesn't look. All these things is because the thick oblique ridge on the second molar region. Both, you can look at that and probably look. How do you expect this thick oblique region, cortical bone to give way for the periapical lesion to appear on the X-ray? So, whenever there is no clear-cut indication, you have to go in for a CBCT. Indication for surgical retreatment, which is in other words, which is contraindication for conventional non-surgical root canal treatment, where the retreatment is impossible. Sometimes, yeah, it is impossible. Failure of retreatment, of course, you cannot be doing it over and over again. Sometimes you need a biopsy, then you need to do a surgical endo. And management options, when you see a radiolucent lesion, when the patient there is a clinical normalcy, and you don't know whether the size is enlarged or not, you can probably review and reassess. Tell the patient there's a radiolucency. We'll see after 3 months. We'll take one more radiograph. That is one of the options. And another is, of course, NSRCT, periapical surgery, and finally extraction. But of course, we are going to prefer this root canal retreatment. Radiographic assessment. Once the patient comes to you, before the radiographic assessment, I should tell you that remember the Crump's differential diagnosis. Look at the periodontal condition. See if it is okay. Look that periodontal disease, rule out any periodontal problem. Look at the contact, look at the food lodgement there. If it is not there, there is no periodontal problem. X-ray also you can look into it, but clinically you look into it. And remember, Crump said poor past, PAST is another tooth. It's quite common. A patient come to you after root canal. It's very common in my practice. I've seen, doctor, 3 years back you did a root canal. Now it is pain. I would be very sure it is not failing. So I give a big smile. I sit down. First question I ask is, does it give you any trouble when you take anything cold or ice creams? Yes, doctor. It's cold. I mean, that tooth is paining. The endodontically treated tooth, yes, root canal treated tooth is paining. You know it is not. So another tooth is one differential diagnosis we should think about. And clinically you rule out all these things. Then you get the X-ray done and radiographic assessment, observation quality, the periapical lesion, any fracture instrument, miscanals, look for the vertical root fractures, look for the periodontal health, and look for the caries below the crown. Caries below the crown is very, very important because the first step in the root canal retreatment, if there is a crown, is going to be a crown removal, crown disassembly. When you have a caries underneath, you have to be very, very careful because when you remove the crown, you can fracture the whole tooth underneath. Understand? So that is first step is the coronal disassembly. I would recommend you to remove the crown every time when you do a root canal treatment, except in very few cases where you are very sure that you will be able to gain access into the root canal without difficulty. A straight tooth which is not angulated, I'm sure it is, I can reach through the crown, do it. Otherwise, if you have the slightest of doubt, don't think of not sacrificing the crown. You have to sacrifice the crown for a good retreatment. So, and go through the crown is only very, very, very few cases. So, you have the various techniques you have. Sectioning I put on the top because I prefer sectioning. Is very, very safe to do it, very, very practical, and you don't need special equipments for it, special instruments for it. And next would be levering and forceps. There is these two techniques. There is a risk of tooth fracture, and this is the one of the GC forceps. Of course, it's not available easily in India. Probably you can order for it and get it. But I'll tell you, even this is not 100% effective. See, they've got a tip where you can attach the silicone, which gives a good grip. They also give a box of emery. Then you just put this, dip this tip in the emery and hold the crown and pull it out. It doesn't come out. So you need to, take a support from the adjacent tooth and pull it out. The leverage is required. But it is still requires that hand forceps, which is not easy to get and not very successful just at one stroke. Sectioning is very successful. I've done all my crown removals only with sectioning. Lifting devices, yes, you have a metal lift. I mean, very nice. Theoretically, it looks very nice and it is probably effective, but not in a crown which is very, very well fitting. So you have to make a small opening, insert this metal lift and then turn it clockwise. The crown comes out along with the instrument. It does. They've got a very nice system. It works, but not in all cases maybe. And lifting devices, yes, this is one I practice. Orthodontic band remover. So orthodontic band remover, you just create a platform. In here, you see that just cervical. If you put your orthodontic band remover, it won't come out. But you create a platform there, insert the orthodontic band remover, and then pull it out. Again, it is. Now, this is one of the lifting devices. It requires sound tooth substance. This is a lifting device. It requires a sound tooth substance. I remember a friend of mine telling me that he had tried removing it, and orthodontist, removing it, and the whole tooth structure broke because there was a marginal caries underneath the crown. So that is what I said. Look for the caries underneath the crown. If it is there, be very, very careful. You have to. Splitting is very, very simple, and probably not very simple, but very safe. Right. So these are the other crown removal. I somehow don't like it at all. The spring loader and gun type, I don't like it at all because patients are not comfortable. It's like, I'm sure the people who are practicing would have come across people saying, last time when I got my impacted tooth, they literally hammered with a hammer and chisel, they hit my jawbone. We know as a dentist, we know it's a very good method. No, it doesn't generate heat. It's a very good method, but the patient doesn't like it. So, and you will have to do a little bit of compromise. Likewise, the spring loader and gun type, patient really remembers that for a long time. You don't want to give negative impression on the patient, and it is again not very safe if the tooth structure is weak. So this is very commonly available, but don't use it. Throw it away if you got one. That is my opinion. So of course, other things are all there. These are effective. I think more for theory, I'm giving those. And ultrasonics, yeah, they can probably assist. If it is loosened a little bit, if you're not able to remove it, then ultrasonic might help you. Otherwise, not much. So ultimately, sectioning is the one which I like, and it is a way. I'll just show you how I do the sectioning. Let us consider the most common crown we encounter, PFM crown. So PFM ceramic has to be first dealt with a diamond burr. Make a diamond burr, make a groove there, and then use a TC burr. I use this TC burr from Mrs. White, And there's also other TC burrs also for crown removal. There are tri-hawk burr is there, then predator burr is there, a lot of burrs are there. And with this, make a groove on the metal, because your diamond burr is, it takes a lot of time. TC burr sometimes a new one cuts like a, cutting like butter with a knife, just cuts, and mind you, don't have to really bother. And this one is one of my earliest crown removal cases. In this case, you can see that I've not even made a small nick on the natural tooth structure. It is not very difficult. See, at this point, I would like to mention, do a retreatment under microscope. Right from the crown removal to the GP removal, to the cleaning and shaping, to the you locating extra canal, ledges, broken instrument removal, everything is efficient only under magnification. So this one, again, if you are afraid, you're going to, of course, this one I did not do under microscope, but still, if you are afraid that you may nick the tooth structure under microscope, you will never do it. So this is how it has come out. And of course, see, I forgot to mention, this would, when you cut it, it doesn't come out. So you have to use a forceps. This is available. It's available here, and this is probably costing you 1,500 to 2,000 rupees. All my PGs have got it. So this is something which I always use. That's and insert this forceps here, and just crush it. It splits it open. Very simple. If it does, sometimes if it doesn't come out, remember the orthodontic band remover which I used? Once you cut through, you know the tooth structure is sound or not. Once you take an X-ray, no cervical caries, you know the tooth structure is sound or not. And once you cut through, the tooth structure is sound, you can use the orthodontic band remover and lifting device you can use. Once you section, you can use it. Of course, this is another full metal crown, going through it again with a full TC burr, nothing else. And then I also use a thick plastic instrument. Somehow I got it, I don't know how I got it. Now I'm not able to get a thick plastic instrument. Just insert in the groove and flex it. You don't have to use thick plastic. You have to find your own instrument, like how Dr. Mahalakshmi had went in for techniques which is out of the box. You will have to think out of the box. What I can insert between this two and then flex it. I would have used a thick plastic instrument, you can use something else. These are all something you don't have to go in for any fancy equipments. Okay? So that is, ultimately sectioning is what I prefer. Coming to the next post removal, you have to assess the risk versus benefit, whether it is really will damage the tooth structure or not, whether it is really right to do the post removal or should I go in for a surgical endo. And depends on the post. And cementation, we don't know what cement was used. If it is a screw post, which was quite common on the retreatment some years ago. When I was doing 10 years ago, a screw post was quite common. Nowadays, I don't see many screw posts. Probably people are using parallel stainless steel and titanium posts and fiber posts. So screw post is not very common, but when it is there, you have to have the wrench, which is given along with the screw post. You have to get that. Be prepared for it. And ultrasonic, yes, you can use it for 10 minutes. The post, when you touch it with ultrasonic, the vibration will loosen the post, will break the cement, and then pulling out will be a little easier. Cast post, you have specific cast post removal tips with your satellite, and this is one. Every company must be having their own post removal. This is one of the cases where the cast post was removed, and make a small groove there, and then place the ultrasonic tip in the groove and allow it to vibrate. Again, not more than 10 minutes, because more than 10 minutes of continuous vibrations ultrasonic can result in root fracture. So not more than 10 minutes, maybe 2-3 minutes, try to pull it out, 2-3 minutes, try to pull it out. I mean, you have, I commonly use my artery forceps. Of course, you have specific, this is again, specific post removals are there, you can always use it. And artery forceps will do the job to an extent. So now, of course, another thing I'm not going to deep into it is the fractured instrument, because that itself is a separate lecture altogether. So for your completion's sake, Masaran kit and Terauchi is getting more popular now. Terauchi kits are very useful. In summary, this is the summary. And fiber post is something which you can remove it not by anything. Ultrasonic won't help, pulling won't help. Best thing is to go through the post. It's not easy. It's not as easy as to actually removing a screw post or a preformed metal post. Going through the fiber post is very useful. Root filling removal, yes. Root filling removal is completely has to be removed, but very, very difficult for 100% removal of root filling, getapercha removal. And because without that, you're not going to eliminate the biofilm under the getapercha. So you have getapercha, sealer point, etc., which has to be removed. And getapercha can be various forms, single cone, well condensed, poorly condensed, etc. And the instruments are manual instruments, rotary night instruments. Then you have these two are heat, these are mechanical, this is for heat, and this is solvent. So you have different things which you can use, and a combination of these two remove the GP. And if it is single cone poorly condensed getapercha, H file will generally be sufficient, and especially when wide open apex, H file is good enough. Wide open apex, your retreatment files are not going to be very helpful. And well condensed getapercha, you need to quite often use rotary NITI files. And these are the various retreatment files for you, and you can even use your regular conventional file, which studies have come, both are good enough. Regular files or retreatment files, anything you can use. Regular files, of course, I have seen using CM wire is very difficult. Don't go for a CM wire. Use for regular conventional NITI or R-phase is okay, but not for CM wire. Then you have the specialized instrument, which is protaper from, you have M2, you have reciproc. All these have specialized retreatment files, and these SAF, you know what is SAF is, you know, PUI, ultrasonic irrigation, and XP endo finisher. These days, a lot of studies are being done on XP endo finisher, and according to DDS, this is one of the most promising supplementary instrument to remove the GP. Maximum removal is seen with XP endo finisher R. You know what it is. This is retreatment, protaper treatment. This is the XP endo finisher. You know how it looks. It is XP endo finisher R is size 30 and not 25. Size 30, which is for 0%, you use it at 1000 RPM at a very low torque, 1 Newton you use, and that's how you use the XP endo finisher. Braiding technique, this is sometimes it doesn't come out. Sometimes it looks very easy to remove, but it sticks onto the wall and doesn't come out. So you insert 3 H files into the canal, just bind it on top of each other, and this is how it is. Bind it in each other and pull it out. It's very easy sometimes. You know, this is solvents. Various solvents are available. What is easily available is orange oil, and orange oil is as good as chloroform, and I prefer using it. And it's also got a pleasant smell, so no problem, easily available. So good enough. Orange. Only thing is, remember, orange oil is an oil, so it is effective when the root canal is dry. If use it, if you irrigate it, it becomes wet. Dry it again and place the orange oil. Otherwise, it's not going to be effective. Ultrasonics, yes, for specific cases, especially silver points, it's very useful. GP generally not very important. Silver points removal is mainly you have to uncover the silver point. See, one thing I've seen is people who use silver points, my experience, I've seen them not using a GAC or a composite core. They generally use zinc oxygenol or a zinc phosphate or a polycarboxylate as a core. So when you remove the crown, you find only this cement, which is easy to remove with your ultrasonics. Then you have to engage the forceps, engage the silver point, uncover, engage the Stieglitz forceps, or even a curved artery would do, and gently pull it out. So this is the Stieglitz forceps. It is available in 3 different tips: straight, contra-angled, right-angled. Very, very useful in removing the silver points. Then ultrasonic tip, be very careful with your ultrasonic tip, especially on a silver point, because it will easily break the silver point. So be very careful, just to loosen it and then try to take it out. And this is one of my earliest cases of, you can see the film is the X-ray film and not RVG, one of my cases which we done probably 15, 20 years ago. There was the, now I come to the same slide. So this is just to give you a break, give also myself a break. So where are we? probably halfway through on top of the stairs. Hope I've given something to take you to 3-4 stairs up there. Now, cleaning and shaping. Cleaning and shaping is the most important step, which is very different from the other step, the obturation. Obturation is not very different, but cleaning and shaping is very, very different, so you have to be very careful. So, because the microorganisms are different when compared to primary, because here you have facultative anaerobes, so you have to be very careful with your irrigant. You cannot take it lightly, I prefer a multiple visit for a retreatment, especially when there is a periapical lesion. Stewart et al. Gives a small flow chart for that. That is, he says, a good aseptic technique. Use rubber dam. He says, give a mouthwash for the patient, rinse with the mouthwash, and then disinfect the rubber dam also, and place the rubber dam, and then probably again disinfect the tooth, then make an entry, then adequate installation. Of course, one preparation larger than what you would normally do. If you are used to using 26%, which is normally advised, or 34%, or even 24%, when it is a retreatment, it has to be one size larger, because you'll have to remove the GP completely. So you have to use one size larger, nothing wrong in it. And irrigation, hypochlorite, Stewart recommends 6% hypochlorite, and EDTA. EDTA is very important. Hypochlorite, there is nothing to beat hypochlorite. It is on the best irrigant we have. Under rubber dam, you can use it casually. Without rubber dam, if you start doing root canal without rubber dam, then you tend not to use hypochlorite. So, but hypochlorite is the irrigant for your success. So, you have to place a rubber dam, you have to irrigate with 6% hypochlorite if it is available as advised by Stewart. Then EDTA. Why I am stressing on EDTA here? Because see, remember, of course, the smear layer removal is complete with EDTA, but according to Kishan et al. Study, after 6 weeks, the biofilm becomes biomineralized biofilm. That means hydroxyapatite precipitate on the biofilm, making it a calcified biofilm. That means EDTA, using EDTA makes the biofilm disruption easy. Of course, hypochlorite is very good, but EDTA assists in the hypochlorite action. So that is one thing. Second thing, when you use EDTA, it softens the dentin, and remaining gutta percha, which does not easily come out with your regular instruments, your retreatment instruments or enlarging instruments, sometimes is still there. That softening of dentin can pull it down and can flush it out with EDTA. That makes it easy. Of course, chlorhexidine is the medicament of choice. You can even use calcium hydroxide chlorhexidine combination, because chlorhexidine is known to be very effective against Z. faecalis, and also that it's got a substantivity action. What is expected during the instrumentation, mist canal, ledgers, transportation, all these problems you expect in the root canal, where you want to do a retreatment. This is of course one of the cases. Interesting case, this one was, patient did not want a crown from the previous dentist and came to me saying that the dentist said that once I give the crown, there was pain, sensitivity to thermal heat. I was not believing. He said, the patient said the sensitivity will come down when I put the crown. That is very often you see with a non-endodontist practice, because the endodontist comes there and visits, does the endo, and the crown is the part which he does. So he wants to do it as early as possible. Patient has got pain. He thinks once I give the crown, it will be all right. So the patient was not convinced, came to me, and I just thought it was wondering why root canal treated tooth was, and no other tooth was involved. So then I went and found that it's a freshly treated tooth, only few weeks, and MB2 was there, that was still giving sensitivity. And for the patient's problem, the MB2 was separate, exiting separately. Naturally, if it was left alone, it would necrosed all right, but it would have failed after some time. And this is the magnification, the picture. You see that without magnification, you will not be able to easily locate all these canals. I mean, this probably would have been missed because of the previous endodontist did not have the magnification. And see that the very clear-cut isthmus there, and I've enlarged that and obturated. Another case where there's a joining, the MB1 and MB2 is joining, and there are so many of these cases where missing MB2 is quite common with the failed endo. This is unfortunate. This was one of my friends' father who was treated by an endodontist, and he said there's a problem after 3-4 years. I took the radiograph, it was looking all right, not only one radiograph, multiple angle radiograph, it was looking all right. I said, okay, fine. Sometimes if we come across bad root canal not failing and obviously good looking root canal failing, it's one such case, okay, let me do the redo. Anyway, it requires a redo. Let me do a redo. But interestingly, I found that this case had a mid-mesial. Mid-mesial adjoining the mesiolingual. It was separate initially. Then as I prepared, I made it into a single canal. That is what you see in the post-operative X-ray. This you see, I hope you see the files where the mid-mesial joining only in the apical third. And but I made into a single canal and obtured. You always try to do that. When the middle mesial is too close to one of the canals, most commonly mesiolingual, try to make it into a single canal because there will be an isthmus between the two, which can be reason for failure. So remove the isthmus, make it into a single canal, and then obture it. So that was a case where mid-mesial canal was reason for failure. What not? I mean, anything can happen. So this was 1 year follow-up, beautiful healing. This lesion, and this is a nice little lamina dura and the pedial space, just 1 year. And this is again a dentist, a periodontist who had root canal done when he was doing his schooling, and after years later he came to me for root canal, for the redo. And of course this cases, you see, look at this, this is a blunderbuss apex. Any blunderbuss apex, what do you do? You prefer, if you're doing it, of course this is, first choice is doing apexification. Regenerative, yes, yeah, but here I did apexification and with MTA, and then the warm vertical compaction, because it has to be, this wide canal you cannot be doing it, lateral compaction is very difficult. So warm vertical compaction for this is again, as I told you, a C-shaped canal, which is the patient had come from UK and he came with a failure. Obviously, as I told you, C-shaped canal is not very easy to treat even by an endodontist. It takes a lot of time. So here, apart from this ledge in the mesial root was also a problem. So I had to go through the ledge, enlarge it, keep the C-shaped in mind, and then enlarge it sufficient time to intracanal medicament. And I've obturated. I still don't have the post-op because he's yet to come, because it's more than a year now. When he comes next time, probably I have to see the post-op. And this is long back when I did. Sometimes the endodontists do a root canal, and if it fails, they do a apical surgery. And apical surgery, just episectomy without any retrofill. This has been very common by non-endodontists. And if those cases come, you don't have to do again a surgery. All you have to do is orthograde retreatment, place MTA. Now, this is one of my more than 15-year-old case. That is why the film myopia, the quality of the film is not as good. And this case, these sort of cases where you have well nicely placed post, retrofilled tooth, you cannot be doing an orthograde, going for a surgical retreatment. Calcification, yeah, you remove the GP, whatever they tried to place in the previous operator, and then like any other calcified tooth, go through it. Ledges is the biggest, again like a C-shaped canal where you have to spend more time. Ledges is one irritating, nagging situation which I face. I mean, it is easily said than done. I will probably give you a diagrammatic representation. I took a lot of time trying to draw this on the computer with your, what is that, Paint, MS Paint, just to give you a description of how we do it. First you remove the GP, all right? Then you place the file. The file goes and hits a concrete wall. You get a feel that as if you are hitting a concrete wall. So that is something you should realize. You're not going to get your canal from there. You wiggle, EDT, and nothing is going to happen. So you will have to curve the canal towards the curvature, and you will have to have the stopper which will indicate where the curvature is. I hope as an endo-PG you understand what I'm talking about. You teardrop, you hold the teardrop in this area of curvature or line, hold the line in the area of curvature. That is very important. So, and once you go in, you will not know which side the curvature is. So, place it, place the curvature, size 10 or even size 8 file is okay. Place it along the curvature and then go slowly. This takes a lot of time. Search for the sticky feeling. The concrete wall feeling you have to feel a sticky feeling. That is this, I'm just saying, but it takes time. It takes 15, 20 minutes, half an hour, more than that. a sticky feeling you will get. Once you get that sticky feeling, then you wiggle, don't leave it, wiggle, go to the apex. That is again, then you prepare the canal. Of course, as I told you, it is easier said than done. It's not as fast as you showed. It's going to take a lot of time, but you need patience, right? So this is, this is a ledge in the coronal third and obturated. This is the ledge in the middle third, obturated. This is the case which I was talking about initially. This was a failure, all right? You see a big failure in the mesial root. You see a small failure in the distal root. That is where you will have to be very careful. The failure on the distal root is not exactly on the root tip, but somewhere little sideways, which is not very uncommon for a distal root. The ledge, it was hitting against that. It was not going beyond. I could not do a patency filing. That means there was a curvature. There was an acute curvature going distally that resulted in the distal radiolucency. That one, right? And that took a lot of time to get into the distal radiolucency, an acutely curved file and search for it, get a sticky feeling, reach the apex, and then carefully enlarge it, and then you obturate it. And this one is healing. It's still, I still have to follow it up. It's about 3 months, 4 months since I've done it. I've not still changed the crown. It's still an acrylic crown, temporary crown I've given. I've still not changed the crown because it is reasonably large lesion. I don't want to change the crown unless I see a complete healing. Summary, and this is it about the problems we face, right? Obturation. What, sir, you still not finished? You won't talk about obturation. How long are you going to take? No, I told you, obturation is no different. So no different. I mean, Stewart says use AH+, use Grossman sealer, if you remember the flow chart. But that was some time ago. But today I find AH+ is good. I use Seal Apex. I get a very good result with Seal Apex. And newer bioceramic sealer are known to be as antibacterial as any other sealer. So any good sealer is okay. So it's no different unless you choose the proper sealer. That's enough. I just want to conclude by saying this is when you do a primary endo. Okay. Don't think I'm an endodontist, I will never see a failure in my own endo. It is possible that we will see it, and pray that the same patient comes to you for a retreatment. They should not go elsewhere. Okay. So when they come back to you, you should know where to stop, where the floor of the core is, where the floor is, right? So I have used this composite. Once I finish the obturation, I place this something called a blue flow I use. I place it inside as a first layer and then do a regular composite core buildup. Of course, it's also available with your Dentsply fluorocore is available. Dr. Karnakaran sir just told me about this. Fluorocore is available with 2 shades, white and light blue. Remember, you should use the first layer of a different color so that when we do a retreatment, when everybody practices this, when it goes to another dentist, he will not perforate the floor. So make sure you have a layer of a different color and then do the core and the crown. With this, I end my lecture. So I hope after this lecture, all of us don't retreat on seeing a root canal failure, but retreat. Thank you.
Thank you, sir, for sharing your profound knowledge.
That was an excellent lecture by Dr. Subbaiah. Hope it gives you all the confidence to give the failed tooth a second chance and attempt treatment. Thank you. Any questions, please? Any questions?
Yeah. People are tired.
My question is simple one, sir. Most of the retreatment files comes with maximum size of 21 millimeters, sir. Now, if you have more than 25 millimeters, we have encoded canine or even your mandibular molar crosses 20 millimeters.
Very true.
So, what to do, sir?
Yes, I mean, this, as I told you, all the studies have shown there is no big difference between the conventional NITI files and the retreatment files. Retreatment file will give you an entry into the file. You can use it. Probably you don't even have to use it. Retreatment file. You can even straight away use your ProTaper.
ProTaper, universal should be fine.
Yes. As you see the ProTaper retreatment files, you see D1, D2, D3 is F3, F2, F1.
Yes, sir.
So you just have to use a size 25 ProTaper, a very nice file for a retreatment, regular conventional ProTaper, very nice treatment for retreatment.
And rationale of using D1, D2, D3, I feel it is more stiffer compared to your ProTaper universal files. Do you have specific rationale for using where to prefer a ProTaper universal and or a retreatment?
Yes. The F3 is very similar to D1, but the differences are that it is short. So one more important difference is it is not the typical NiTi which you see with your ProTaper instrument. The F3 is a typical
Stiffer.
conventional NiTi. This is much more stiffer. So especially when D1, the coronal third and also in the middle third, you need a little stiffer instrument because GP removal is not very easy with a very flexible instrument. So that case, you also have a retreatment ProTaper set with you. Don't just depend on the regular conventional NiTi, except when it is a long canal, where as you said, where this will not reach, and you would need a conventional NiTi to remove the GP.
Thank you, sir. And one more last question. So you showed one force up to create a leverage force between the two splitted crowns.
Yes.
Actually, what is the brand and what is the cost? I have never seen such a forceps. The first time I am seeing this. Previously, I used to create the leverage force with my rotary diamond itself.
Okay.
I prefer to use a straight fisher, long
This
straight
one,
fisher.
it's available easily when the exponent. I think there's one exponent coming now, isn't it? I think so. Chennai exponent.
Chennai March exponent, yes.
It is there actually, and if I will send you the address of the person. Probably, if anybody is interested, we can contact Srinivasan sir and get the detail. I will send it to him by tonight.
Yeah, sure. Usually, if you create a leverage force, the part which has a less retention will come out easily. The other part you have to use either your orthodontic band remover,
Yes.
or again you have to make a nick and again.
Yes,
The
yes,
same thing.
yes. When the split, many times only one part loosens. So you remove it and then take it out. The other part is still there. Sometimes it's very, very firm also.
Yes, very firm. Yes.
That's where you create a platform and orthodontic band remover. By the time you know the two structure is strong, so orthodontic band remover you can use it. If it is weak, you have to cut it again this way, the occlusal surface towards the mesial or distal.
Yes,
whatever.
again, we have to make a
then you will
vertical
have to split it again. So that's right. Very good question.
And last one question, sir. And how to determine which means you said for all the cases no need to remove the crown. Do you have any specific conditions where not to remove and where to remove, sir? Because we won't be it's not possible to evaluate the underlying tooth.
That's why I was stressing so much on remove the crown, sacrifice the crown. Sometimes you think the crown is so good, you don't want to remove it. No, you don't want to do a second mistake there. Already patient has come with a problem. You don't want a second problem. Explain the patient, yes, the removal of the crown is good. I almost invariably try to convince the patient to get the crown removed. Unless it's a lower molar, that's where I prefer. Lower molar, very straight, but probably I take a small chance in trying to go through the crown. But invariably try to convince the patient to remove the crown.
Yes, sir. Thank you so much.
Thank you, sir. I request Dr. Thilanayagam sir to please felicitate Dr. Subbiah sir.
Thank you.
I request Dr. Thilanayagam sir to please felicitate Dr. Amudalakshmi ma'am. Thank you, ma'am. Thank you, sir. Now let us have the privilege of listening to the Honorable Great Speaker, Dr. Pradeep, sir. Pradeep sir is the professor, head of the Department of Conservative Dentistry and Endodontics in Thai Mogambike Dental College Hospital in Chennai. And sir has done his undergraduation in Annamalai University and post-graduation in Tamil Nadu GDC. Sir has done his FDS RCS in the Royal College of Surgeons, Edinburgh. He has national and international publications. His research interests are in the vertical root fracture. And I now invite Dr. Pradeep sir on the stage to deliver his lecture on cracks and fractures, identification and management.
Good evening. Okay. I'll try to make this as short as possible. Come in the front. Can I have everybody in the front, please? My topic is vertical root fracture and cracks and fractures. These are the parts of my lectures: Kray's lines, fractured cusp, cracked tooth, split tooth, followed by fracture necrosis, root fracture, root microcracks. Then we have vertical root fracture or VRF, types, findings, X-ray features, CBCT, finally predisposing fractures and treatment. Okay, what is a crack? It's a break or a partial discontinuity in tooth structure, while a fracture is actual separation of parts. In crown we can have Kray's lines, fractured cusps, cracked tooth and a split tooth. So let's see them one by one. What's the first one? Kray's lines. Where do you see Kray's lines? Enamel. So Kray's lines is an incomplete fracture of the enamel, seen more in adult patients. So the Kray's line travels up till the DEJ. The DEJ is a sort of stress breaker which prevents passage of the crack into dentin. So Kray's lines are mainly in enamel. So we check with trans illumination. The lights pass through. Okay. The light passes through, that means it's a Kray's line, it's only there in enamel. Light does not pass through, the crack is passing through dentin. Usually other tests are normal. There is usually no treatment. We may seal it with resin if there is any discoloration. If the tooth has tenderness, we have to evaluate for subluxation or root fracture, otherwise no treatment. So treatment is only aesthetic, etch and seal the Kray's line. Next we have a cracked and fractured cusp. So usually it will be a diagonal or angled crack separating the cusp from the rest of the tooth. Usually the crack will avoid the pulp. Okay. This is where we have to raise a flap to see the extent of the crack. You can see it somewhere in the root. We see a crack propagating in the root. You can see the reason also. It's a large restoration. The cusp is unsupported, leading to a cracked cusp in response to masticatory forces. In early stages we have pain on mastication. It may be difficult to localize in a vital tooth. Mainly we have symptoms of reversible pulpitis, bite test, pain on release of bite. Other tests are magnification and transillumination. Later stages, the cusp separates from the rest of the tooth, however the pulp may still be vital. They can fracture because of large restorations or because the cusp is unsupported by dental caries. And this is something you must remember while making a restoration. When do we cap a cusp to prevent cuspal fracture? When the restoration extends more than 2/3 the distance from the central fissure to the cuspal tip, you will have to cap the cusp, otherwise the cusp is prone to fracture. Treatment. You can treat it with a composite restoration only or with a full crown. If it is a cracked cusp, cracked means there is no movement of the parts. If the cusp is fractured, again the treatment can be a restoration or a full crown. If the pulp is involved, root canal treatment followed by a crown. Any doubts in this fractured or cracked cusp? That's fine. Next we have a cracked tooth. So how do we identify a cracked tooth? Usually it's a line crossing the marginal ridge. Pits and fissures usually do not cross marginal ridges. If we see a line crossing a marginal ridge and the tooth is symptomatic in the absence of caries, we suspect a cracked tooth. How is it caused? Occlusal forces, wedging effect of cusp fossa relationships, bruxism, excursive interferences, age. Teeth may become brittle with age, sometimes traumatic biting injury, and can be associated with large restorations, or sometimes can be associated with intact teeth. You can get in both sides, intact teeth as well as large restorations. Again you can see a crack line crossing the marginal ridge on both sides. Usually affected teeth are mandibular maxillary maxillary premolars, usually mesiodistal, non-localizable pain, and again sharp pain on release of the bite. Tests done are bite test and transillumination. Transillumination, light does not pass through the crack. Light stops at the crack. One part of the tooth will be dark, one part will be bright. Treatment. Usually you will get pulpitis. Initially reversible, later it goes to irreversible pulpitis and then necrosis. This is because many of these cracks are not diagnosed. They may report with pulpitis, then slowly progresses to necrosis. Treatment of teeth with reversible pulpitis. Remove some dentin to expose the crack. You should be recommended to place an orthodontic band for a few months. If the symptoms stop, we can go ahead with a full crown. This has been documented by Wu et al. In the latest JOE, March JOE. So we give a band, wait for 2-3 months. There is no pain, you can go ahead with a full crown. So what happens for vital cracked teeth? Do they become non-vital or do they go to irreversible pulpitis? This person who has followed them for 3 years, and he says 30% of them may go to irreversible pulpitis and may require root canal in future. Rest of them stay normal. Another 6-year evaluation. These people say only 20% of them may require pulpal intervention. So it's possible to teeth a cracked tooth without RCT, at least for a few years. What happens when the crack involves the pulp, irreversible pulpitis? Then we'll have to do root canal and a crown. This case was done by who? Can you see? A previous speaker, Subbiah. So he did cracked tooth. You can see he did the RCT. Again, this another crack, again by Subbiah. You can see it's quite an extensive crack, maxillary molar. He's got 4 years follow up. Again by Dr. Subbiah. Okay, what happens now? After RCT, tooth with crack, we have done an RCT. What happens in the follow up? This person, Kang et al. Has said they survive for at least 2 years. 90% of them survive for 2 years. What are the factors associated with failure is, if the tooth has got a deep pocket, then it's better to extract. Otherwise, they usually survive for a few years at least. Another thing, 5-year follow-up study. This says coronal cracks are easy to treat, while radicular cracks may increase the chances of the tooth being extracted. So it depends on the location of the crack, whether it causes the CEJ and goes into the root. And this again 2019 JOE article. What happens if you have a crack in the root canal itself? So they said to do the obturation, then we fill up the area where the crack is with a geomer, that is fluoride releasing glass particle containing cement, and then they have about 2 to 4 year follow up. Okay, what is there a poor prognosis for cracked tooth? Yes, when the crack is more extensive, when there is mobility of fragments, extension of crack into tooth, or the tooth is associated with a deep pocket. Otherwise, we can treat them more or less successfully for at least a few years. So what happens if the patient does not treat the cracked tooth? The cracked tooth becomes a split tooth. Then it's better we extract the tooth. So what is this? Fracture necrosis, a non-vital, seemingly intact tooth. It appears intact, but it's non-vital. So what do we suspect? We suspect a crack with pulpal necrosis. Again, we see a deep, narrow pocket mesially or distally, along with a halo type of bone loss. Halo type is all around. We see a bone loss. And this was reported by Burman and Cutler in Journal of Endodontics 2010. Poor prognosis, better to extract. Okay, take home. This is a take home only for this part. I'll be continuing. So, cracks occurring in the crown are Kray's lines, cuspal fracture, cracked tooth and split tooth. Diagnostic tools are bite test, dice and transillumination. Cracked tooth can be treated with crowns with or without RCT. Without RCT, if the symptoms are of reversible pulpitis. Irreversible pulpitis or crack extending to the pulp, we have to do with RCT. Okay. Then we come to fractures in the root. Okay. Root fracture. This can happen after trauma. Coronal segment, mobility, bleeding from the gingival success, tender. Pulp status is inconclusive. Do you think the pulp will be vital or non-vital in such a case? Yes? Yeah, good. Yeah, that's a good. Thank you. So, root fracture. How do you see this in an X-ray? Horizontal fracture, we can see in the regular IOPA. Oblique fractures may require variation in the vertical angle of the X-ray, or may need a occlusal view. Otherwise, you can take a CBCT. Treatment. Retreatment of all fractures, anywhere it happens, reduction, immobilization. So, we splint it. For how long? Up to 4 weeks. Coronal fractures close to the CEJ up to 4 months. So, favorable healing is younger age, approximating fragments to below 1 millimeter. This is types of healing: calcified tissue, calcified and connective tissue, or with bone, or the last one is where it does not heal and there is granulation tissue. Okay. Pulp necrosis happens in about 25% of the cases. Then usually pulp necrosis happens only in the coronal fragment, as JP said. So, we do RCT only for that area. If there is a periapical lesion, it may be necessary to remove the apical fragment by doing a surgical procedure. So, success is better healing happens when the fracture is more towards the apex. More the fracture is more towards the CEJ, more chance of contamination from the gingival sulcus, more chance of failure. Again, as the fracture goes towards the apex, mobility also will be less or more? Less. Yeah, lesser mobility as the fracture moves towards the apex, more mobility as the fracture is towards the crown. So, better healing when the fracture is towards the apex. This is a crown root fracture, also called a shovel fracture. This may require post core and a crown, sometimes gingivectomy to increase the chances of isolation at the fracture site. We have to be done. Sometimes you have to do orthodontic extrusion or surgical extrusion to bring about success in this case. We are not going to go too much into this. This is just a crown root fracture. Okay, take home message. Fractures occurs in roots due to trauma, horizontal or oblique fracture. Pulpal necrosis may occur around 25% of horizontal root fractures. Crown root fractures require post and core followed by crown. Again, how come pulpal necrosis occurs only in 25%? Why can't we have more number? So, pulpitis is inflammation in a closed chamber. When you have a fracture, if there is inflammation, there is chances of the inflammatory fluid to dissipate outside. So, there is chance of the pulp being alive. Okay, now, we have root fractures not associated with trauma. Two types: root dentin microcracks and vertical root fracture. Actually, both are same. Initially, it may be a root dentin microcrack, which later on progresses into vertical root fracture. As you will see, root microcracks. They can happen in non-endodontically treated teeth. That is, before root canal, in normal patients, you can have a root microcrack. Many reports in Chinese population. Here, this is a report in Indian population. Who did this? I did it. Okay. So, Pradeep Kumar et al. Okay, so this is the next one. So we have prevalence of around 7%, more as the patient grows older, more in posterior teeth. They occur mesiodistally. So it means a normal, when a patient comes to you, he may have a crack in the tooth before we do the RCT, which may progress into a vertical root fracture in future. So another report, majority, which again says the same thing, majority in the older age group, they were associated with teeth with attrition, pocket of greater than 5 millimeters, mainly in mesial root of mandibular molar, the pre-existing cracks before we even start the treatment. This is an example. You can see a premolar with a vertical root fracture. Again, a CBCT. Can you see the crack here? Mesial root. You can see a line from the mesiobuccal canal to the outside. Next, we come to vertical root fracture. Most commonly associated with endo-treated teeth. Most commonly in maxillary mandibular premolars, mesial roots of mandibular molars and mesiobuccal roots of maxillary molars. So, longitudinally oriented fracture of the root usually found in the buccolingual plane. Fracture initiates in the root and may extend coronally. Usually the fracture does not cross the CEJ, it stays only in the root and may be seen long after the root canal has been done. Oh, this is my college and we have doing a lot of research on vertical root fracture. This is our OP. So, prevalence of vertical root fracture 3.6 to around 20% in endodontically treated teeth. So many of endodontic teeth which come with failures may be because of vertical root fracture. Types, we have coronal, mid-root, apical. Apical fracture may extend to buccally to lingually or palatally. It may be seen on both the sides. So, complete and incomplete fracture. Incomplete fracture only one side, complete the tooth is split into two pieces. It's a diagnostic challenge. This is a sort of sinus tract associated with a vertical root fracture. There may be absence of radiographic findings and there may be only vague signs and symptoms. So, one of the key findings is a coronally placed sinus tract. That is, sinus tract is placed in the attached mucosa. If the sinus tract is there in the alveolar mucosa, it may be more closer to the root tip, which may be more indicative of periapical infection. This is placed more coronally, more in the mid-root level. There may be a narrow pocket in the later stages. Multiple sinus tracts, more than one sinus tract with the same tooth is indicative of vertical root fracture. This is a narrow pocket associated with a vertical root fracture. So, a periodontal pocket is wide coronally and becomes narrow as you go towards the root tip. VRF pocket is a thin, narrow, pencil-like pocket. Another thing, the vertical root fracture pocket is usually seen buccally or lingually, because that is where the fracture is. Buccolingual fracture, again pocket will be buccally or lingually. Periodontal pocket usually we check mesially or distally. So that's the periodontal probe, that's a plastic probe. Since we are checking for pockets buccally or lingually, we will have to go past the crown and into the gingival sulcus to check for the pocket. So, it's better to use a flexible plastic probe to check for VRF pocket. Again, if you raise a flap, you can see bone loss on the surface of the root. So, again, even though there is so much bone loss, it may not be seen immediately on the X-ray, because this is buccal bone loss, buccal to the root tip. Unless the bone loss extends mesially or distally, it may not be seen in an X-ray. So, usually we elevate a flap, remove the annulation tissue and visualize the crack line, usually under a microscope, to diagnose a vertical root fracture. So, when does it occur? Again, it is usually seen around 4.5 years after doing the root canal treatment. So again, take home, prevalence is 3 to 20%. Mean time from root canal treatment to vertical root fracture is around 4.35 years. Mostly seen in premolars and molars. Early signs, discomfort, and later signs of coronally placed sinus tract with narrow pocket. Plastic probe is indicated to evaluate the buccolingual vertical root fracture pocket. Okay. Next we come to imaging and VRF. This is a study done by Tamse et al. They are saying the various types of radiographic presentations of a vertical root fracture. First one is periapical, second one is perilateral, third one periodontal, vertical bone loss, furcation radiolucency, and this one is uniform widening of the periodontal ligament space. And the most common one is the halo radiolucency. These are all the different types of radiolucencies which is associated with the vertical root fracture, and usually they are associated with well compacted obturation. The obturation looks reasonably good, but there is a radiolucency. Then we suspect a vertical root fracture. So this is the most obvious sign of vertical root fracture, halo-like radiolucency or a J-shaped radiolucency. J means it starts from one root or one surface of the root and goes into the other surface like this, J-shaped radiolucency. CBCT. CBCT, you may or may not be able to see the actual crack unless the vertical root fracture, the size is double the size of the voxel of the CBCT. But we can see the bone loss associated with the vertical root fracture and also the guttapercha or metal post may cause artifacts preventing identification of the vertical root fracture. So, this are the 5 findings on CBCT which were consistent with confirmed vertical root fractures. First one is mid-root bone loss. You see a sort of hole, a punched out shape mid-root associated with a fracture. We can't see the fracture, but you can see a mid-root bone loss. Absence of the entire buccal plate, which can be again confirmed by elevating a flap. Radiolucency around a root where a post terminates. Usually the post will terminate in the mid-root. There we see a radiolucency in the CBCT. Radiolucency between the buccal and lingual plate and the root surface. Large radiolucency from one plate to the other. And this is where when we have a large vertical root fracture where the fragments are slightly separated, we can see the actual vertical root fracture in the CBCT. VRF width should be double the voxel size to be able to see it in the CBCT. So, what is the voxel size of CBCT? Approximately 76 microns to 125 to 150 microns. So, we have a VRF double that size, then we can see it in the CBCT. So, if we increase the resolution, better chance of seeing the vertical root fracture according to Vanderlei et al. Also, if we increase the milliamperage or the current, better chance of visualizing the VRF. Then this was a MRI. They found that you could also see vertical root fractures using an MRI. As an alternative to CBCT, we can also use a MRI to visualize a vertical root fracture. And this is a systematic review and meta-analysis done by Indians, Talwar et al. They found that vertical root fracture was easily seen in a CBCT if the root canal was empty, that is there is no guttapercha or post in the root canal. If the root canal is obturated, then it is very difficult to see the vertical root fracture even while using CBCT. So, the best way is if you suspect a vertical root fracture, to check where the pocket is, elevate a flap and see whether there is actually a fracture or not. You take home. So, early VRF cannot be detected using radiographs. Most common X-ray findings are halo and J-shaped radiolucency. CBCT, we can see bone loss surrounding the vertical root fracture much earlier than radiograph. VRF width has to be twice the voxel size of the machine to be visible in a CBCT scan. So, finally, how to confirm a VRF? By doing an exploratory surgery. Then we have VRF predisposing factors. What may lead to a VRF. We have iatrogenic and non-iatrogenic. Iatrogenic, we have endodontic procedures. Since most of them occur in a root canal treated teeth, we think that the way we do the root canal may have a role in causing the VRF, especially in procedures which remove a lot of dentin, such as post and core. Non-iatrogenic depends on the actual dentin thickness in the root and canal anatomy, and of course age and parafunctional habits. Other things are effects of irrigants and medications on dentin. A strong hypochlorite solutions may weaken dentin, and effects of bacteria dentin interaction may also cause some collagen degradation and weakening of dentin. Tooth wear, occlusal loads can also lead to weakening of the tooth and lead to a fracture. Where above they have reported that there is a higher maximum bite force in endodontic treated teeth than in the corresponding normal tooth, because these teeth may lose their sensitivity to evaluate how much bite force is happening on them. So, higher maximum bite force is seen in endo treated teeth. Sclerotic dentin mostly seen in patients above 40 years. They have a 20% reduction in fracture toughness, increase in collagen linking with age, change in dentin microstructure and composition, and reduction in dentin damage tolerance. All this leads to, as the patient grows older, the dentin becomes lesser resistant to masticatory forces and other forces and may have a fracture. Root shape, when the buccolingual diameter is broader than the mesiodistal diameter. Example, maxillary mandibular premolars, mesial roots of mandibular molars, such are the teeth where VRF are more commonly seen. Canal, suppose as you do BMP, if the buccal dentin is made thinner than the lingual dentin, we have increased strain concentration on the thin buccal dentin, and this may lead to fracture. So, it is better to have uniform dentin thickness all around the root canal. Round canals have better uniform stress concentration. Oval canals may have stress concentration in one area, which may lead to a fracture. So, rounder the canal, the better it is. Crown design, pores should be used only when essential for retention of the core material. Otherwise, please do not remove excess dentin to place the post. And presence of a ferrule is also very important in preventing root fracture. So, what about post space preparation? In the root cross section, we have inner dentin and outer dentin. Inner dentin is more hydrated, more porous and less mineralized, and removing that dentin when you are doing a post space preparation may predispose the root to fracture. So, do not use a post whenever it is not necessary. The use of a post is only for retention of the core. So, like this, when you remove dentin for placing a post, there may not be any uniform distribution of stresses, which may lead to a fracture at a later date. This is a study which says that post placement and root canal treatment are the major etiological fractures for root fractures. Lateral compaction. Stress due to lateral compaction may lead to root fracture. So, spreader loads of more than 1.5 kilos may lead to a root fracture. So, it is better to use a night tie spreader, which gives lesser force when you are doing lateral compaction. And what size we are supposed to use? 25 size, not more than that. Again, when you are doing warm vertical compaction, smaller the tip, the better. Plugger size, the better. And smaller the canal size, the better. So, what size spreader? 25 size. What size plugger? Smaller the better. Instrumentation beyond the apical constriction. This we can prevent. If we do this, there is more chance of apical cracks forming. These are examples of overfilled teeth which may lead to a vertical root fracture. So, overfilling is something which we should avoid to prevent damage to the apical constriction. Again, this is another study which says that overfilled teeth are more associated with vertical root fracture. So, please try to avoid overfilling. Please stop at the apical constriction. Effect of root canal instrumentation. Do rotary instruments, can they cause fracture? Use of rotary instruments. So many in vitro studies are saying that root canal instrumentation can lead to micro cracks which may become fractures at a later date. So first they were doing these experiments on extracted teeth in the lab. So that's not the correct way to do it. We need to do it at least with something simulating periodontal ligament. So what did they do? They did this in what? In a cadaver. So did the same experiment inside a cadaver. They found that cracks were not formed. Do instrumentation in a cadaver tooth, cracks were not formed. So to even better improve on this, in our college we did this in vivo. We did not patients indicated for orthodontic treatment. So one side we did hand protaper, one side rotary protaper, then extracted the tooth and did a micro CT. 1 out of 48 samples had a crack and it was associated with an area of thin dentin because of this groove present. So we found that instrumentation per se may not cause a crack, but if it is associated with such narrowing of dentin, there are chances that we may get a crack. Also this one crack could have been caused by the extraction forces also. So root canal preparation may not induce dentinal cracks in vivo inside the patient's mouth. So are teeth, endodontic treated teeth more brittle? No, says this article. Similar biomechanical features in both endodontic treated teeth as well as non-endodontic treated teeth were found by Sedgley et al. Reduction in stiffness. Endo treatment causes minimal reduction of stiffness, while removal of dentin for doing a access cavity or removed cavity will cause more loss of tooth stiffness. Rigidity. Root canal treatment will not reduce the rigidity of the root by much, but post space preparation may reduce the rigidity of the root. So that comes to mainly the effect of dentin removal. More success, more the dentin you leave inside after completing the root canal. So according to Gutman, the amount of remaining dentin and root morphology may be the ultimate factors in resistance to fracture. This we must keep in mind while doing any treatment on a tooth. So the reason for VRF, multifactorial. Excessive dental removal, root anatomy, excessive forces during root canal treatment. All of these in the presence of repeated functional parafunctional stress may lead to a future VRF. Also, loss of water may also lead to a reduction in dentin strength, which can also make the tooth more susceptible to fracture. So the take home, this is the last but one take home, only one more. So conserve dentin. Instrumentation and obturation beyond the apical foramen to be avoided. Give a reasonably good ferrule. Do gentle obturation. And what to do after this VRF? Can we repair it? As of now, we don't have the technology to repair a vertical root fracture. So we have to extract the tooth or root as soon as possible. Delay will increase losing bone. There will be a lot of bone loss around the fracture, which may compromise the placement of future implants. What about intentional reimplantation? Can we extract the tooth, seal the crack and place it back inside? So they did it for around 20 teeth. They did it mainly for anteriors and they had a follow-up for 1 year. We didn't get any further results from this group. So I don't think it is going to be highly successful. Posterior, we can do hemisection followed by a fixed prosthesis. So the last one, how to prevent a VRF? Atraumatic root canal treatment, gentle instrumentation and obturation, minimal dentin removal. These are the last take home messages, and avoid over instrumentation and overfill. Thank you.
Thank you so much, sir, for your rich words. It surely helped us to understand the topic.
எனக்கு யார் ஷேர் பண்ணலையா? எனக்கு யாரும் ஷேர் பண்ணலையா? Any question, Kelma? Any question?
Any questions, please?
evening, sir. In a short clinical crown, is it better to place a FRC entrance restoration, what madam was suggesting, or go for a cuspal coverage restoration?
Okay.
Indirect.
So whether to give a coronal coverage or not. If you don't give a coronal coverage, there are more chances of cuspal fracture. So it's better to give a coronal coverage when suppose you are doing a root canal on an intact tooth. We have all the marginal ridges and cusp intact, then we can avoid a crown. If there is loss of marginal ridge or the cusps are weakened, it may be better to cover the cusps.
Effect of calcium hydroxide, long-standing calcium hydroxide on VRF, sir?
Okay, long-standing effect of calcium hydroxide. It was supposed to weaken the root. There were 3 or 4 publications which said that when you do apexification with calcium hydroxide and wait for 6 to 18 months, the root may fracture. But that was disproved in a recent study. They said the reason for root to fracture was thin dentinal walls rather than the effect of calcium hydroxide. So calcium hydroxide as of now is safe.
Cuspal coverage crowns, the onlays are same as the full
Yes,
coverage
anyhow,
crown?
cover the cusp.
That's it. Thank you.
Good evening, sir. Thank you for the wonderful lecture,
thank
sir.
you.
So, do root canal treated teeth have different degree of proprioception? Do they lose their proprioception? Because we learned that pulp does not have proprioception.
Proprioception, yeah.
So
I put one slide
you
like
put
that.
a slide saying that root canal treated teeth receive more force. So what is the basis?
So proprioception is mainly present in the periodontal ligament surrounding the root rather than inside the pulp, most of it. So this study says that they found more occlusal forces in endo-treated teeth than in the corresponding contralateral teeth. So they surmise that the proprioceptive receptors are not really protecting the tooth in that situation, because we need more studies on that. When that study they found that we get more forces in endodontic treated teeth.
Thank you, sir.
Thank you.
If we detect a root crack, you say that there is more chances of VRF in later stages. So in such cases, what do? We obturate. Do we use a bioceramic sealer, or we completely pack the root with a MT or any other silicate cements?
So it's very difficult to actually find a root crack. The study where we showed root cracks was a micro CT study, where we extracted tooth and placed in micro CT. So we found it was a voxel size of around 17 microns. So the width of that fracture was 19-20 microns. Maybe very difficult to find that out in a clinical situation. Clinical situation we can only find out after there is some separation, or if there is bone loss caused by the crack. In those situations, the tooth is as of now doomed. But like you say, the BCS sealer is supposed to induce calcification. Maybe future studies on that, or maybe they may find out better nanoparticles which can induce mineralization and cause closure of crack. As of now, you see a crack, the tooth is doomed.
Sir, one more question
from
my side. The hemisection and after the fixed bridge. So what is the lifespan for the?
It depends on the remaining root structure. If the remaining root is long enough and broad enough, you are going to get quite a long life for that. If the remaining root is going to be short and thin, then it may not be indicated. Better to place an implant.
Thank you, sir. Any more questions? Thank you. Srinivasan.
Thank you, sir. I now request Dr. Thilanayagam, sir, to please felicitate Dr. Pradeep, sir.
Thank you very much, sir.
With this, we are concluding today's session. I request you all to come sharply by 9. Tomorrow, Dr. Balagopal sir lecture starts by 9 a.m. on curved canals and reciprocation. So please be here by 9 o'clock, and followed by Dr. Gopi Krishna's lecture. Yes.
With that, we come to the end of our session. You can please refresh yourself with the tea and snacks, which is being served in the adjacent hall. Thank you all.